Dr. Jihad will join us now, so we can check with him on screen sharing and everything.
Okay.
Just to make test. Let's see.
Dr. Jihad Al-Yafi.
دكتور جهاد كيف الحال؟
السلام عليكم
وعليكم السلام ورحمة الله، كيف حالك؟
دكتور أحمد،
اشتقنا لك والله دكتور جهاد.
كيف حالك؟ طيب،
الحمد لله.
احنا اونلاين ولا لسه الشباب؟ درس.
احنا حنبدأ بعد ربع ساعة، بس قصدي إذا تحب إنه نعمل تيست سكرين شيرنج نتأكد إن ما في أي مشاكل قبل البدء، وبعدين حنبدأ معك وبعدين مع الدكتور المحاضرة الدكتور
اوكي.
سندي. إذا تحب تعمل تيست للسكرين شيرنج.
صوتي واضح؟
صوتك واضح. We have a Dr. Nargiza Satova. She will be moderator of today's session.
Hello, sir.
So,
Hi guys. Hi Dr. Nargiza.
Okay.
Nice to meet you.
Nice to meet you too. So you can share your screen by the time we
Yes.
will check.
Yeah, just a second.
you can see a share button من أسفل الشاشة، في ضغط على زر شير من هناك ممكن تحدد نوع السلايدات، تضغط على السلايدات.
Yes, sure. Share my screen.
ممكن تعمل شير من الكمبيوتر سكرين كامل بحيث إنه يكون أسهل لك، أو إنه تعمل شير للباوربوينت برزنتيشن مباشرة.
Yeah, this is لحظة share and then ماني شايف البرزنتيشن. So
فتحت البرزنتيشن.
yes, it's open. And then share.
ممكن تختار تعمل سيلكت شير ماي كمبيوتر سكرين بحيث انه اي شيء تفتحه في الكمبيوتر احنا بنشوفه مباشرة. هذا حيكون اسهل.
Share setting. Yeah. There we go. Clear?
Yes. Now you can make presentation mode. Yes, sir.
Yeah.
Okay, ممتاز.
Great. Very good. Do you have any videos? If you don't have, you don't need to play them. If you have, maybe you want to.
No, I didn't have videos.
Okay, good. Thank you.
Okay, everything looks very good. Okay. So maybe now you can exit screen sharing, Dr. Ajhad.
Yeah.
And then when we start, we can share again, okay?
Okay. So it disappeared now?
Yes, I stopped from my side. We still have Dr. Sandeep who will join us now, and we should check with him for screen sharing also as well. And at
Okay.
7 sharp, we should start.
We will. إن شاء الله.
لنا منك كثير يا دكتور جهاد ما شفناك.
ها؟
لنا منك كثير ما شفناك.
جزاك الله خير.
اشتقنا لك
دائما
والله.
غلطة. الله يحفظك.
دائما
ما شاء الله
نذكركم
عليك.
بالخير
والله
والله.
الأيام دي جت فيري بيزي يا رجل بشكل. عندنا أبها في الصيف الإشكالية زحمة. زحمة
ايوه
في
احنا
الشغل. حياة.
نفس الشيء يعني، حتى عندنا هنا نفس الخبر.
لكن الله يجيب الخير إن شاء الله.
ان
حاولت
شاء
أنا
الله.
أشوف البرزنتيشن، ما رحت في يعني كلاسيكال برزنتيشن وكذا. رحت في الأدفانس مانجمنت، تمام، اللي كلها ريسيرش طبعا.
اكيد يعني، وهذا هو
آه.
عنوان المحاضرة الأخير.
هي خليتها على أساس الريسيرش
بتكون
ليفل.
يعني معلومات مفيدة لنا جميعا أكيد إن شاء الله.
إن شاء الله بإذن الله.
يا دكتور إبراهيم النعمي، كيف
والله أموره
تتواصل معهم؟
طيبة. ماشي. إبراهيم أول أمس نتكلم. أمور طيبة، ودنا ننزل حملات بس إن شاء الله تزيد الأمور بس.
إن شاء الله بإذن الله.
الله يجيب الخير. كيف أجواكم في أمطار عندكم؟
يعني بدأ شوية شوية، مش زي ما كل سنة أمطار
حتى هنا.
قليل هذا
حتى
السنة.
هنا نفس الشيء.
يعني الجو هذا السنة يعني حرارة زيادة عن اللزوم أكثر من كل سنة.
أيوه. عند صنعاء ما فيش
هذا احنا في
مكيفات.
صنعاء، عاد عندكم سعودية، عاد أنتم أكثر. بس صنعاء قد احنا بندور مكيفات في صنعاء، أنتم عندكم الله يعينكم
والله
الصراحة
سبحان
يعني.
الله يا ترستنج. الحين شغال مكيف. حمى.
أكيد. لك والله في صنعاء قد بدأت المكيفات تنتشر هذا الفترة، قد كل المحلات يعلنون على مكيفات من الحمى. أول مرة في صنعاء يحصل هذا الشيء.
الله
فكيف
المستعان. الله وفق فيه.
عدن، الحديدة، سعودية، الله
والله
يعينكم.
عدن.
So Sandeep, how are you?
Hello, sir.
Hey, good. How are you?
We are
So,
good,
I'm
thank you.
good.
fine,
Now
Akila.
we can see you. Great.
Yeah.
Yes.
So I'll just share my screen and let's see that's
Yes,
working
sir.
out.
Okay.
You got it?
Yes.
Yes.
Presentation.
Perfect. So I'll just, everything is working fine. So I'll just,
You can
If you
see your
want,
whole computer screen.
yeah.
If you can, yeah.
Mhm.
So I think it's good. So I think everything is set. So we should start in 7 minutes from now. Is that right, Dr. Najiza?
Yes, sir.
I
So
will
I'll come back
contact
after
Dr.
10 minutes.
Okay.
Okay.
I will contact Dr. Salman Sharif.
Okay.
Join. And everything will be good.
Inshallah.
Okay. Dr. Salman Sharif will join us now. I will just send him a link. No problem.
Good evening, Professor.
Good to see you. Good to see you.
Assalamu alaikum,
Nice
Dr.
to meet
Salman.
you,
How are
sir.
you?
Assalamu alaikum.
I'm good. How are you keeping? I'm sorry, I had my thing on the WhatsApp, and that's why I just wanted to transfer onto my laptop.
Nice to have you, Doctor. And it's a great honor to have you with us and without your support for our medical educations and webinars, we cannot have all this. So thanks you very much from us.
No, it's my pleasure. And really what you're doing is excellent for the people all over the globe, and especially this region. And I'm happy that you're pushing things, and we need to continue doing this and make sure that our people in our area are not deprived of all the good things that we can learn.
That's all. Thank you, Doctor, for those nice words. Today it will be our last webinar of Module 4. So after that, we will have maybe 1 or 2 months break. And after we complete the 7th conference of the Yemeni Neurosurgical Society, it will be held in December, inshallah. And after that, we can do a 5th webinar on peripheral nerve. Inshallah, I will discuss that with you later.
Inshallah.
So, Professor, I will leave things to you and Dr. Narjiza. So,
Narjiza, please go ahead and invite our excellent speakers.
Okay. Hello, good evening, everyone. Welcome to our comprehensive weekly online educational program, module number 4, spinal cord. Yemeni Neurosurgical Society, in collaboration with the World Federation of Neurosurgery, Young Neurosurgery, Forum WFNS-YNS, the Pakistani Society of Neurosurgeons, Neurosurgery Couch, Neurosurgical TV, is pleased to announce our final webinar, where today we will have 2 speakers, Dr. Sandeep Vaishya and Dr. Jahed Al-Yafi. Let me introduce also our chair, Professor Salman Sharif. The first speaker will be Dr. Jahed Al-Yafi, the consultant neurosurgeon and spine surgeon with the Tedavi Medical Group, Saudi Arabia. And the topic will be advances in management of complete spinal cord injuries. Welcome, sir. You can start.
Okay. First of all, good evening, everyone. I don't know anyone at the morning time. Good morning. It's a great honor to be with you today, and I would like to thank Dr. Ahmed, Dr. Salman, and Dr. Narjiza for this. Even Yemeni, it's a great honor for me to present for Yemeni Neurosurgery webinars, and thank you for my colleague speakers and all attendants. I'm going to talk about spinal cord injury. I try to make it as simple as I can because most of the advances in spinal cord injury, as all you know, it's research topics rather than something practical on daily basis. So traumatic spinal cord injury remain the most devastating condition, affect approximately 27 million people globally, an incidence of 93,000 new cases each year, according to results recent studies. Spinal cord injury, it has a social, a patient-related social and economic healthcare system impact negatively, and that's why I think it's one of the most active topic of research globally. Spinal cord injury complete and incomplete due to trauma or high speed or RTA or falling down. The pathophysiology, which is the basis for the new research and the new advancement in management. As we know, the primary injury is due to direct impact and that cause immediate vascular structural damage like spinal cord contusion or transection. Secondary spinal cord injury that could happen within 24 hours, 24 to 14 days, subacute or chronic up to 6 months, especially the acute and subacute phase. It is the target of the new advances in management. Example of acute injury including hemorrhage, necrosis, apoptosis, and myelin breakdown. An example of chronic changes, Wallerian degeneration and scar tissues. So the main target of the new research and studies is to intervene within acute stage to prevent or minimize the effect and not to reach most of the chronic changes that we see in the spinal cord. As we said, the consequences for spinal cord injury is devastating. It has psychological effects on the patients and families, society, healthcare systems. It has also economic impacts. Assessment, as we all know, there is like clinical with different scale. Most common scale is AC and Dermal scale. CT, MRI is essential. Now I'm going to go through the current management landscape. I try to make it brief as I can because each one it has. I need 2 hours to talk about the different study that goes through. This is the general management, respiratory, pharmacological, and operative. Operative, as we all know, now the trend from different research, including Michael Feeney's group, that surgical intervention in spinal cord injury as early as possible. And again, the aim is to prevent the effect of secondary injury as a consequences of chemical cascades and so on. Advancement, this is the topic of today. So there are neuroimaging biomarkers for spinal cord injury, molecular biomarkers for spinal cord injury, advances in neuroprotection, advances in neuroregeneration and neuromodulation and neurorehabilitation. I'm going to go through each of one. Neuroimaging biomarkers of spinal cord injury. We are talking here about the MRI mainly. Advance in MRI, it shows detailed tissue, microstructural and functional analysis of the spinal cord injury, and it adds a prognostic value on short and long-term plan. T2 weighted image is the one most commonly used, and this is impacted in practice in, I think, all over the world, in all centers. Other study which is of prognostic value is diffusion tensor imaging, magnetization transfer image, myelin water fraction image, and MRS and functional MRI. Regarding the T2, when we see these findings indicates worse prognosis, white to gray matter signal intensity, a high brain and spinal injury center score. It's shown here. There are scoring system based on the MRI findings and the signal changes on T2 image. The higher the score, the worse the outcome. intramedullary edema, and so on and so forth. So these are the new advances in study a patient with spinal cord injury. Some are, or most of these new ones, still research centers rather than clinical practice. We have a myelin water fraction scoring system, or MAPS. Actually, it quantifies the amount of myelin interruption or degradation because spinal cord injury. We have the magnetic transfer, or MT. All of these studies quantify the myelin. MRS is like any brain lesion. The necrotizing tissues has inverted ratio of choline choline. And we have the functional MRI, which is interestingly, we know functional MRI is helpful in brain lesions, but here again, in brain and spinal signals and sensory motor signals, functional MRI is of prognostic value. The DTI, which is the most commonly used after T2, DTI actually, it quantifies the use of fractional anisotropy, FA. It measures the degree of water molecule diffusion restriction in region of interest. So the water diffusion is parallel or across the fibers. When there is increase in the diffusion restrictions, it means there is more damage and the prognosis is worse. So if we do a DTI pre-intervention, and then we do the procedure and we do the DTI after, it will show how much restriction change in diffusion, and definitely of prognostic value. Now, the molecular biomarkers of spinal cord injury. The molecular biomarkers, it's actually targeting the chemical cascade that happened in secondary injury. We have the inflammatory cytokines, especially interleukin 6 and 8. Generally speaking, these markers elevating in CSF within 24 hours after spinal cord injury. And as long as the level, I mean, it's a proportion relation. So the level high, the amount of injury is severe. With less amount of these markers, the severity of injury is less, and it's a prognostic value. We can repeat after 6 months. Again, the same relation. Interestingly speaking, the microRNA 9 and microRNA 219. The finding or identification of these markers in CSF indicates myelin degradation and injury for microRNA 9, and indicates parenchymal of spinal cord injury for microRNA 219, again of prognostic value. The presence indicates the injury. The higher level, the more severe the injury, and the less level, the less severe the injury. The serum biomarkers in acute and chronic spinal cord injury, we have elevated structural proteins that's released in serum, like GFAP, neurofilament light chains, and so on. The level, if it is elevated in the serum, indicates more severe of the injury, and vice versa. In chronic cases, elevated serum of interleukin 6 and 2 receptors are predictors for neuropathic pain, pressure ulcer, and urinary tract infection, which is interesting. I mean, if you find it in serum at high level, these patients are prone for complications. Neuroprotection. There are like the neuroprotective therapy or strategy for spinal cord injury. Again, it's all targeting the secondary phase of spinal cord injury. We have the excitotoxicity, ionic dysregulation, mitochondrial dysfunction, lipid peroxidification, inflammation, and apoptosis or necrosis. Each step of this secondary phase of spinal cord injury, the research try to target it and to see the effect on the prognosis. We have the anti-excitotoxic agents, including NMDA receptor antagonists, magnesium. They used it. It's, I mean, research is not conclusive, but they say using magnesium associated with better outcome. The most of the research nowadays about the non-NMDA receptor antagonist, especially Riluzole. Riluzole which is sodium channel blocker, is extensively studied and investigated through a randomized controlled trial, multi-center randomized placebo-controlled double-blinded trial by Michael Phoenix and his group. This study unfortunately was stopped during COVID crisis. That's why it was interrupted prematurely. But the result, they said the efficacy of riluzole in patients with cervical spinal cord injury, it meets the primary endpoint of efficacy of study, which is the improvement in ASIA score. And it has a beneficial effect in function and quality of life in Asia PMC. Biomarker study revealed riluzole and reduced axonal degradation as indicated in serum phosphorylated neurofilaments level. So again, sorry. I need to minimize this. So riluzole is one of the drug that is now used in clinical practice and research studies. I know they use it in Toronto, Michael Phoenix. Now they need to look for the secondary outcome and long-term outcome of riluzole in this trial, crisis trial. Advances in neuro regeneration. Well, I mean, molecular and cellular approaches both enhance their delivery to the site of injury. Molecular approaches improve spinal cord injury microenvironment by stimulating trophic effects, targeting inhibitory components of neurosurvival. I mean, regeneration, they target the inhibitory, they inhibit the inhibitory factors for the regeneration, and they improve or stimulate the stimulator of regeneration. The neurotropic factor that stimulate neuroregeneration, including brain drift growth factors, ciliary neurotropic factors, connective tissue growth factors, neurotrophin 3, fibroblast factor, glial cell nerve growth, VGF. Again, the inhibition or the inhibitory of myelin decomposition products, they try to improve or to develop agents that inhibit this one and improve the regeneration. These are different types of study that are conducting through NOGO trial, ROC, RHOA ROC system. A recent trial of NOGO-A inhibition in acute spinal cord injury showed promising in targeting these pathways. There is nothing still under research, nothing in clinical practice. We have advances in pharmacological agents that neutralize myelin-associated inhibitory foster conductive environment. So again, the cell transplantation using stem cell and neural cell promote tissue repair and regeneration. It's among the advances of neuroregeneration steps. We have all other pharmacological agents that try to improve the regeneration. The cell transplantation, either stem cells or neuronal cells, promotes the repair and stimulate the regeneration by stem cells in animals models, axonal remodeling by embryonic stem cells. Still under extensive research, other options of cell transplant is the pluripotent stem cells and neuroprogenitor stem cells, neuroprotection by mesenchymal cells, myelin sheath by oligodendrocyte progenitor cells. I mean, all these are, again, the cell transplantation spinal cord is one of the topics that showed extensive studies. It shows some promising results, some side effects, some failure, but still not, I mean, applied widely in clinical practice. They also they implement the gene therapy with cell implants and trying to do a combination of both. Advanced neuromodulation. Neuromodulation actually is one of the emerging modalities for spinal cord injury. And most of these modalities, we see it in rehab centers, including the basic of neuromodulation to improve sensory and motor signals between brain, spinal cords, and the target organs, either muscle or sensory endings, either through electrical stimulation, magnetic field stimulation, ultrasonic stimulation, and in combination with brain-computer interface. Electrical stimulation, the most commonly used is the spinal cord or epidural electrical stimulation, or we call spinal cord stimulation implants. Is widely used for spinal cord injury and for non-spinal cord injury like angina and others. It has a very good promising results. Magnetic resonance imaging also being used, ultrasound waves. But I would say the most commonly used with clear result and effect is the spinal cord stimulation, epidural one. This neuromodulation in rehab centers, it gets conjoined with rehabilitation maneuvers. So they start the stimulation in the muscles or sensory ending, and they end up stimulating the spinal cord and even the brain-computer interface and vice versa. So one of the well-said statement that combined neuromodulation and neurorehabilitation therapy, when combined, it improves the post-spinal cord sensory-motor circuits. It facilitates immediate and long-term motor function recovery. It's a multimodal approach that enhances volitional movement and adaptive plasticity. Advanced and assistive technologies. Physical therapy for spinal cord injury, there are a lot of advances in it. Again, we see it at the rehab center. As a surgeons or as a clinical not working in the rehab center, we don't see it, but they have a lot of improvement in physiotherapy, in assisting aid for spinal cord patients. They are using robotics, AI systems, and so on. I try to make it very concise. Each topic of this, either implants, biomarkers, regeneration markers, it needs a separate lecture. Maybe next time we will make it, hopefully. The home message traumatic spinal cord injury present with significant challenge and significant pathophysiological steps. It has, despite all the advances, all the research, it's still patient with spinal cord injury, they have a burden on themselves, on family, on society, on healthcare system. The challenge of translating advanced clinical approach. This is the main point. There are a lot of research, but the challenge we face now, how to improve this clinical research outcome to improve the neurological outcome as reflected by evolving guidelines. Recent advanced management opened the door for new hopes. Still research ongoing. One of the, I would say, promising research that's conducted. Now it's on hold because of COVID, but I think gonna resume it. The RISES trial for Riluzole as a medication given spinal cord injury. Last meeting we attended in Neurospine, Michael Feelings, he presented spinal cord injury, cervical one, and he's using it routinely in all spinal cord cases, waiting for the conclusive result. I think it's going to be applied worldwide. Thank you so much. I'm sorry I make it very short, and I'm happy to hear any comments or questions. I don't know how you end or
You can stop sharing.
yes.
Yes. Dr. Jihad, thank you very much for a very interesting presentation. A lot of new information. So far, we don't have a question in our chat box. Maybe somebody wants to give a comment.
Yes, please.
Narcissa, I'll just say this was a very good talk, and it's just at the right time. There is so much happening in the world at the moment regarding the recovery of patients with complete spinal cord injury and what kind of recovery they're achieving. And it's amazing what's happened nowadays. So about 7, 8 years ago, I visited Switzerland with a friend of mine who started doing brain-machine interface. And since then, I've seen they've evolved and done amazing things. And now they're able to replicate in all the other countries in the world. And what they are doing is unbelievable. So that dream of making up somebody walk with a complete spinal cord injury is not a dream anymore. It's a reality. And a lot of people are working on it. It obviously it's expensive at the moment, very much, because just like, if you get a robot, then robot costs extensive amount of money, through which people get physiotherapy. And with the AI, they see what areas of muscle are weaker, so they work on those muscles more than others. So there are so many things happening. On top of it, just the simplest thing, ribosol is excellent, but you can use curcumin or simple stuff which is used in majority of the people in subcontinent in Asia. It's freely available, it's very cheap, and that can be used as well. So there are so many things we can do, and it's amazing. And thank you for your talk, and really enjoyed that.
Thank you so much.
Dr. Saleh is writing. Thank you, doctor, for your wonderful lecture. I have one question. At your hospital in Saudi Arabia, at Tadawi Center Group, do you use any biomarkers in your management and investigations?
Saudi Arabia, there are King Faisal Specialist Hospital in Riyadh, which is the biggest research center. I think they are doing some of the serum and CSF biomarkers, but as far as I know, there is no clear study or something published. Also, they are trying to targeting gene therapy. They have a very good genetic center. They are doing a lot of research about gene therapy, but unfortunately, most of the centers where the spinal cord injury, they are not a big research center. But hopefully in the future, I think we are from the meeting we are attending. They have some insight toward this.
Thank you so much.
Thank you.
If anyone will have other questions, please put to the chat box. I think, Professor Salman, we can move to the next speaker.
I think so, yeah, please.
Let me introduce Professor Sandeep Vaishya, Director and the Head of Neurosurgery at Fortis Memorial Research Institute in Gurgaon, India. And topic will be complications management and avoidance in spinal surgery. Sir, you're welcome.
I'll just share my screen. Can you see my screen?
Yes, we can see. Could you make a presentation mode? Thank you.
Firstly, it is my pleasure to give a talk to Yemeni Spine Society, and so I thank Nargisa for that. Now, this topic is very wide, so it can go on for hours. All the complications, the possible complications, and their avoidance in spine surgery. So I'm just briefly outlining the complications and then focusing a bit on cervical spine, which is where the people are more scared to go. And so in an elective spine surgery, any complications should be very rare. In certain high-risk surgeries like acute trauma or intramedullary tumor or big deformity surgery, the risk can be higher. So complications can be of various types. One can go on the wrong side, on the wrong level. There can be position-related complications, neurological complications, hardware-related complications, infections, many other complications like CSF leak and others. So why complication deserves structured attention? Because overall complication rates in various series have been 10 to 24%. And in revision surgery, deformity, multi-level construction, complication rate become much higher. So there can be approach-related complications. You can do soft tissue injury, vascular injury, or visceral injury during surgical corridor creation. One can have neural injuries like direct nerve root injury or a spinal cord injury or ischemia-related injury to the spinal cord or the nerves. There can be malposition of the implants, pseudoarthrosis, graft failure, adjacent segment disease, or there can be systemic and general complications like infection, CSF leak, thromboembolism, or positioning-related injuries. So one of the common problems can be level-related injuries, so level-related complications. So one has to standardize how do you identify the level. So either you do it from C2 and down to sacrum or down below from sacrum. But you have to have a standardized thing. And particularly in mid-dorsal levels, it can become more challenging. And if you have any intra-op imaging like CT scan or O-arm, then you can use that. So positioning related injury, there can be direct impact on the eye because of pressure. So you should confirm and recheck the position, and the anesthetist should check that whether on the horseshoe there is, when you're using a 3-pin, then the pressure on the eye is not there, but with a horseshoe there can be pressure and you should check it. Then there can be brachial plexo ulnar nerve injuries because of traction or compression from positioning. So you should pad all pressure points, keep the arms in a neutral and stretched position. There can be skin and soft tissue injuries, pressure injuries over the chest, the iliac crest. So again, you should use soft supports for these pressure points, and you should check them at regular intervals. Among the peripheral nerves, neuralgia parasitica is one of the most common complications, and it can happen up to 20% patients. Though it is a short-lived thing, it improves over a few days, but it can be there. So in an obese patient, one has to look for any compression on the abdomen so that there is no backflow, there is no venous pressure. And in females, particularly in obese females, you have to take care of the breasts also, otherwise there can be fat necrosis. These are examples of our department where we had these pressure injuries over the last few years, so we had a collection of them. And so whenever we see this next day on the round, we take a photo and send it to the anesthetist to take more care next time. So this is the data of our department, which was taken a few years ago. It was published in Euro Journal of Anesthesiology. So we analyzed the data of venous thromboembolism. Out of 8,500 operative patients in 8 years at that time, roughly 60% were spine and 40% were brain. And the incidence of perioperative venous thromboembolism was 0.5%. It was 42 out of 8,500. And male, female were equal. 2 patients died due to massive pulmonary embolism. In 5 patients with significant pulmonary embolus, our cardiac surgeon extracted the thrombus, and all 5 patients survived and did very well. So I'll now focus a bit on anterior cervical spine because people are most of the complications occur in this region, and people are worried about this anatomy there. So the complication can be vascular, neurological, soft tissue, or implant-related complications, or CSF leak. So overall, this was a paper published by Nancy Epstein a few years ago, and she mentioned that the overall morbidity rates were 13 to 19%, the commonest being dysphagia. There was then postoperative hematoma, increase in myelopathy, recurrent laryngeal nerve palsy, CSF leak, wound infection, increase in radiculopathy, Horner syndrome. I have also seen one Horner syndrome many years ago in one patient. So I always used to wonder how could it happen, but that patient had it. And then respiratory insufficiency, esophageal perforation, which is again a rare complication but can have a mortality rate. And then instrument failure, meningitis, epidural abscess. And there was a single case report of internal jugular vein occlusion and phrenic nerve injury. Again, there can be pseudoarthrosis. It will depend upon the number of levels fused. As the number of levels of fusion increase, the incidence of pseudoarthrosis increases. From single level fusion, where the pseudoarthrosis rate is 0 to 4%, and going up to 56% in 4-level fusions. So, and the reoperation rate for symptomatic pseudoarthrosis was 11%. So one has to be careful in these patients. Now, among the vascular complications, the incidence is very low, but there can be potentially devastating outcomes. There can be direct injury to internal carotid artery, external carotid artery, vertebral artery, internal jugular vein. It can cause pseudoaneurysm formation. There can be injury to thoracic duct. There can be perioperative stroke. So in my career, I have seen two patients with perioperative stroke. And actually, one was after, both were after lumbar spine surgery, and they woke up with a stroke. So it was not a direct compression of the vessel, but patients just had it. And so I have seen one patient where my associate was opening and he caused direct injury to internal jugular vein. And by the time I reached there, there was significant blood loss. We had to compress it for a long time, called in the thoracic surgeon, cardiovascular surgeon to repair it. And that was the patient, I think because of prolonged compression, their patient developed a Horner syndrome on the opposite side. And so this is you can see the anatomy here, the internal external carotid arteries are there. Injury is rare because of the carotid sheath. If you don't open the carotid sheath, the vessels are generally preserved. In an abnormal anatomy, sometimes you can be misled and can cause direct injury. So it can be because of knife, chisel, or drills. Self-retaining retractors can cause this. So you should intermittently release the retractor if there's a prolonged surgery. So if there is a carotid injury, you can directly put a pressure on it by finger. You can minimize manipulation, avoid thrombus fragmentation and embolization, and balance the compression to allow some blood flow. Otherwise, the patient will have a stroke. If there is a life-threatening bleeding, you can have a temporary clamping, which will have a high risk of stroke though. And in in one or two patients in transfemoral surgery, we had a carotid artery injury. So we immediately tamponaded it and took the patient to an endovascular lab, and then they put in a covered stent to cover the site of the leak. So simple sutures or patches are sufficient for minor injuries and small wall defects. Sometimes you may have to do a resection with end-to-end anastomosis or resection with an interposition graft. And one option can be transposition of external to internal carotid artery. I would suggest that if you have facility to have a vascular surgeon there with you in these type of injuries, it would be of great help. So monitor blood pressure to reduce bleeding, and most common complication of cerebral thrombus and reperfusion issues. So jugular vein can be hidden behind sternocleidomastoid. It's thin-walled and can be easily torn, and as we saw in one of our cases. So whenever there is an injury, the carotid sheath should be opened, repair the wall with suture. They are usually suturable, and in rare cases you may have to ligate it. But if there is bilateral injuries, you have to reconstruct it. You cannot ligate both the internal jugular veins. Again, vertebral artery injury can happen if you go too lateral, particularly while doing oncovertebral joint resection, or the instrument is placed too lateral. So you can see here there is a safety zone, and the vertebral artery is just lateral to that. So if you go too lateral, you can damage it. Neurological injury is approximately 1% because most patients have bilateral, the vertebral arteries on both sides, and the vessel can be supplied by the other vertebral artery. Unless you injure the dominant vertebral artery, the risk of neurological damage is less. Again, direct exposure and repair versus tamponade. Direct exposure and repair is not very easy in anterior surgeries, while in posterior surgeries, one can do that because the whole vertebral artery is there in front of you. And it can lead to pseudoaneurysm, ischemia, hemorrhage, or fistula formation. So you should review the preoperative CT MRI for any abnormal anatomy, particularly when doing C1, C2, or CV junction surgeries from posteriorly, and avoid blind lateral drilling here. So keep in mind the spinal cord width is just 8 millimeters. So you are pretty safe if you remain you go from midline to lateral, and then you should be aware that not to go beyond the oncovertebral joint. So again, thoracic duct injuries are rare but serious complication of ACDF. It can lead to chyluria, and more often in left-sided surgery. Normally, I do all my surgeries from right side, so I've never seen this. Though I've had thoracic duct injury sometimes while doing brachial plexus injuries, but I've never had any problem with that. So it must be ligated. It says the mortality rate is 50%, but I have had few leaks there. And then sometimes you could not even repair it, but I've never seen any complication related to that. Again, neurological complications, laryngeal nerve injury, cervical sympathetic chain is there, glossopharyngeal, hypoglossal nerve are there, and then spinal cord and nerve roots are there. C5 root syndrome is one of the commonest problems. Our incidence is 3 to 5%. It was 3% in anterior and 5% in posterior surgeries. Usually recovers in few weeks. Commonest onset is 2 to 3 days after surgery. In a rare instance, I saw a patient who developed C5 root syndrome 2 days after surgery, recovered in next few days, and then again developed it 2 weeks after surgery, and then took few weeks to recover again. And another patient, the weakness developed 15 days after the first surgery. So it can be a very delayed thing also. And cervical sympathetic chain, if you do significant dissection of the longus colli muscles laterally, then you can injure the sympathetic chain, and it can lead to Horner syndrome. So again, one of the most challenging things is dysphonia and vocal cord paralysis because of recurrent laryngeal nerve injury. And if you search the net for anterior cervical spine surgery, this is the commonest cause for litigation in US. So it is usually transient. It can last from weeks to months and very rarely permanent. I've never seen one actually. And most common complication would be hoarseness, weak cough, dysphagia, and aspiration. So I'll just skip this. These are the mechanism of recurrent laryngeal injury. It can be direct surgical trauma. It can be because of pressure or stretch. It can be postoperative edema. And sometimes it can be because of endotracheal intubation cuff pressure. So here it is showing the mechanism. So I'll skip this. So basically you need to do careful dissection, proper sharp tooth retractor placement. It should be beneath the muscle, and monitor the ET cuff pressure and deflate the cuff and reinflate after retractor positioning. So again, dysphagia is a pretty common problem in most of the patients after anterior cervical spine surgery. And usually it is very short-lived. Most patients don't complain it after a few days. Sometimes they can be because of hematoma, infection, or swelling, or multi-level surgeries have got a high risk. So these are the other nerves which can be damaged. These are very uncommon. Again, esophageal injuries can be potentially fatal, particularly if they go unrecognized. Incidence higher in corpectomy, where you are using a lot of drill. It is associated with excessive retraction during dissection. In a reoperation where there is a lot of scarring or inflammation, it can be there. So in reoperations, we invariably put in a nasogastric tube so we can palpate it and identify which part is the esophagus. So if you identify the leak, you can immediately and you manage it with keeping in nasogastric tube for a few weeks and atropine to reduce saliva and avoid hardware in these situations. And if there is a delayed diagnosis, there can be persistent wound drainage. You can ask the patient to swallow methylene blue, and if it is coming out of the drain, that obviously there is a esophageal injury. So I've already gone through this. So in OPLS, the CSF leak is much more common, and it is because of excessive traction on the ligaments. So anterior repair is usually impossible. When you're doing a posterior surgery, you can directly repair the dura, but particularly when you are doing a discectomy, it is very difficult to do any repair. Even in corpectomy, the dura is involved with the OPLL, so it is usually irreparable. So we normally use fibrin glue, hemopatch, or Duragen, and put a patient on subarachnoid lumbar drain for a few days. Just showing an example of where you can anticipate. So this was a patient who came with acute injury. And so we operated him within 6 hours of, I think within 20 hours of injury. So he was Asia A actually, and he was father of our physiotherapist. And so we immediately took him to OR, operated him, and you can see he started developing movement. And I think it took him 6 months, but he started walking later on. So this was the patient, this was the kind of injury where you would anticipate CSF leak. His dura was completely torn, and we had to repair it with patch and glue. So this is example of lumbar spine surgery where, so there was just a partial dural tear. The arachnoid was intact, but invariably we put in a stitch. This is through an 18 mm tube. So we suture it whenever possible. So you can see the arachnoid is intact, but we still suture it because it can occasionally rupture later on and can cause postoperative pseudomeningocele formation. So with just 2 stitches, it was repaired. And so this is a patient operated elsewhere. So he came with this big cavity formation and all the nerve roots were prolapsed. So you put the patient in Trendelenburg position. Whenever there is CSF leak, put the patient in Trendelenburg position. Because of the reduced CSF pressure, you can push the nerves back in and then you repair the dura. Again, this patient had a bad OPLL, hypertrophic ligamentum flavum, completely calcified. In this patient, you can anticipate preoperatively that there is bound to be CSF leak. So this is the patient, and you can see when we are lifting it, when we are lifting this bony ligamentum flavum, there is no dura there. You can directly see the exposed nerves in the spinal cord. And so we repaired it with Duragen and fibrin glue. Again, this patient I was operating and there was an inadvertent tear. So we put the patient in Trendelenburg position. Oops. I'll just forward it. So we could not push the nerves in, so we extended the cut in the dura. And then it was easier to push the nerves back in. And then we did a... So you push it back in and then did a direct repair. So advantage of tube as compared to an endoscope is that in tube you can invariably be able to repair the dura. Again, infection in cervical spine is a very, very rare thing. This is the only patient with cervical spine where I'd seen an infection. It was an 84-year-old patient. He was operated elsewhere for a lumbar spine surgery, woke up quadriplegic. They had completely ignored his cervical stenosis. He woke up quadriplegic after his lumbar spine surgery and was like that for next few months when he came to me. So we did a corpectomy, and you can see we did C6 corpectomy and fixation. Everything looks perfect. The guy was quite all right. Oops, where did it go? So he came with this swelling after 6 weeks. And so he just sent me this photo. In next few days, he started pouring pus out of the wound. Here you can see that. So this was his MRI, and you can see the graft was completely dislodged. There is significant pus in the anterior space. There's a lot of inflammation in the posterior space also. In the posterior spinal muscles, you can see there is a lot of inflammation. So we removed his implant. We went and really debrided the wound. We used stimulant granules, which can be antibiotic coated. We formed a graft because you can shape it in the form of a graft, though it will be absorbed after 6 weeks. So we put in a graft to give some support and put him in a halo. And then 6 weeks later, we did not fix him posteriorly because there was a lot of inflammation in the posterior spinal muscles also. But 6 weeks later, then we went in and did a lateral mass fixation. We did not go anteriorly, and this is the guy 6 months after surgery. So at that time, I thought that in 84-year-old guy, we may not be able to make him survive. While infection in lumbar spine is much more challenging because of the muscle bulk and the fat is significantly more, and there is a lot more space for the pus to collect. So one can use simple antibiotics, one can biopsy and culture, you can do wound debridement, you can do vacuum dressing, or in worst case scenario, you have to remove the implants. In particular, in fusion patient, if there is infection, I am very aggressive. I open the wound, debride it thoroughly, do vacuum dressing, then the wound heals, and then close it. So implant-related complications, I'm not going too much upon the implant-related complications. There can be subsidence, particularly because of osteoporosis. It can pull out, screws can be misdirected. So you have to pay attention to biomechanics. So This is one of our cases where we did a corpectomy, and you can see this is post-operative X-ray. 3 months later, we do routine X-ray every 3 months in these patients till we see fusion. And if you see here, the cage has subsided. The patient did not have any problem, but because of the subsidence of the cage, we supplemented it from behind. So C3 to C7 fixation was done. Again, this patient was operated twice in 2 different countries. When he came to us with this, patient had a C567 microdiscectomy and a C6 corpectomy. If you see the implant, everything is wrong. The screws are placed in the disc space. Actually, only one screw is placed here. The other is because I think it was going over the next vertebra, so they did not put in the screw. The plate is completely tilted, and the cage has completely subsided, and there is significant kyphosis here. He presented with weakness in both upper limbs, recurrent laryngeal nerve paresis, and significant dysphagia. That's why we decided not to go anteriorly. We just left it alone, and then went behind and did decompression from behind and just fixed it. It did quite reasonably well. Again, these are the kind of implants that you don't want to see. So this is some artificial disc which has come out, another one. And here the C1, C2, you can see the occipital screws have come out and the plate is tilted. And here, so these are the complications my junior pulled out from the internet. These are not my complications. Oh, this is very interesting one. Salman, if you remember, I sent you this. So this was a young female. I was doing an artificial disc, and so my junior exposed it and then called me in the theater. So I just looked it at the Siam, and I saw this photo. I thought that he had placed this dissector to check the level, and it has been placed outside. And then I scrubbed, and then I went in, and I saw that this was going through the disc space. So he had put this thing in to identify the disc level. My heart literally sank, and I did not know what to do, because I was pretty sure that this, like you can see, this has gone beyond the cord, and I was sure that the patient is going to wake up quadriplegic. But luckily, there is a cord somewhere. So this thing had missed the midline of the cord and had gotten literally, it had just pierced the dura, and the patient woke up without any neurological deficit. So, like, these things can also happen. So robotic assistance, we are using robot for last 1 year. And so this is elimination of brain trajectories. We don't use it in every patient, but in difficult patients with thin pedicles or bad scoliosis, then we use it. Again, there can be obstruction of airway because of glottic edema, pharyngeal edema, hematoma, CSF leak. So avoidance of complications is possible only with the good knowledge of anatomy, meticulous dissection and techniques, and careful check with intraoperative radiology where implants are being used. I have not covered intramedullary tumors or thoracotomies because the field is too wide. So I just concentrated on one aspect of this thing. Thank you.
Professor, thank you very much for the wonderful presentation with a lot of cases and experience. Indeed, important notes we made. Anybody wants to have comments or questions?
I think that gives an excellent talk. Sandeep has covered. Sandeep, can you please unshare so we can see you? Thank you. Thank you for a wonderful talk. I think you've covered all the important points, especially for young neurosurgeons, when they're starting out, what is the way forward, what are the things to expect. And when you're starting out cervical, you're not sure that, what kind of outcome you'd have. And once you're aware of the anatomy, then life becomes much, much, much easier. And with experience, obviously, things look so simple and easy. But you need to have your guard up and need to be ready for any complication in this area and make sure that it's all sorted. So an excellent talk. Thank you, Sandeep.
My pleasure. Any questions?
So far, no questions in the chat box. Thank you so much for the excellent presentation. Thank you for your lecture.
Okay, bye-bye.
Ahmed, if you want, we can wrap up.
Thank you, Dr. Sandeep, for this wonderful presentation. And also, I like to give my thanks and gratitude to Dr. Salman Sharif, Dr. Nargiza, and also Dr. Shahid Ayub, and Dr. Ahmad Riaz Raja, and Dr. Abu Dhar Kangur for their support for this educational program and for their tremendous help, and also to Ahmad, who also the man behind the screen usually. So thank you everyone, and thank you, Dr. Sandeep, for this very nice presentation. And if there is no more questions or no more comments, Dr. Salman, we can wrap up this presentation, and we can see you all, inshallah, after preparing for the 5th module after the conference, inshallah.
Inshallah.
So
We thank everybody. Thanks, Nargisa.
thank you. Thank you, everyone.
Thank
So I
you.
hope.
Good night, Ahmed. Bye-bye.
Okay, bye-bye.
Thank you.
Bye-bye.